Hello, this is Dr. Lauterbach, and this is a Key Points mini lecture of adolescent assessment. Objectives are to identify some red flag clinical conditions that occur in this age group, to identify the significant physical and psychosocial development milestones, talk about evidence-based approach to health education in the adolescent age group, conduct a health risk appraisal for an adolescent, and some information about pre-participation sports physicals. These are conditions that occur in the adolescent age group to be aware of. Hodgkin's lymphoma emerges in this age group in terms of prevalence. There are a lot of things that can cause the lymph nodes to swell in this group. They're being exposed to viruses that can cause lymphadenopathy, including Epstein-Barr virus. But if they have these other symptoms, with fever and night sweats, you should be prepared to send them for a full evaluation with ultrasound, perhaps biopsy, to rule out Hodgkin's lymphoma, a highly treatable cancer, but one that you want to catch. And testicular cancer, now that they're going through puberty, boys have an increased risk for developing testicular cancer, which would be a hard bump on one testicle. And if you have the full history of the patient, you would be able to find out if they had cryptorchidism as an infant, which is a strong risk factor for the later development of testicular cancer. Boys in this age group also have increased risk for developing testicular torsion. That particular complaint presents with severe onset, sudden onset of severe pain, and it is a surgical emergency. You have to be mindful that once girls have achieved their first menses, they are at risk for ectopic pregnancy and pregnancy in general, but in terms of abdominal pain, ectopic pregnancy would be another surgical emergency, and then in the psychosocial behavioral area, suicides are a concern. This slide just goes over Erickson's stages of psychosocial development. As a review, you're not expected to reproduce this on a test in this course, and you saw this, of course, in your undergraduate programs, but just to bring to your attention, hopefully they will have accomplished the tasks of 1 through 4, so we're focusing on 5 and 6 in the adolescent group. So we'll talk a bit about early adolescence. This would be 11 to 14-year-olds. And you can see the normal developmental findings that occur with this age group. The practitioner approach doesn't have much information on in the slide here, is to assure confidentiality to the early adolescent, to build a relationship both with the patient and with the parent, and to coach the parent on ways to permit the exploration and development of autonomy that's happening, while at the same time providing for safety, because their ability to assess risk of their own behavior is not good at this point, and to bring up more sensitive issues like smoking and drugs, alcohol, sex, and safety in general. In middle adolescence, the 15 to 17-year-old age group, or the high school students, going to be working on affiliated individuation, trying to figure out how to relate to a group and how to establish themselves as an individual. Girls will, by this point, have completed their Tanner development, and the males are going to be in the process of finalizing that development. Peer groups dominate social life and influence behaviors. They're becoming more focused on academic success than in the lower grades, and economic realities are coming into relevance for these kids. And experimentation, trying to understand who they are, trying different things. The world is opening up to them, and they're going to try different things. So our focus is to work both with the patient and the parent to help them put some safe boundaries around that experimentation. By late adolescence or early adulthood, we are now leaving high school and going into entering into the workforce with a job or college or both. And independence is a major issue. They're trying to become an adult, and but still having uncertainty about whom they are in terms of their relationships and their work and their identities of various types, including their sexual identity. And our approach is to be very reassuring about protecting their confidentiality so that they will feel more comfortable talking about things that are important, and to approach them as the adults that they are becoming. Parental advice now is to allow independent healthcare visits, be available and supportive, and to deal with their own issues of separation as this human that they've been raising becomes more independent and needs to separate from their parent in order to complete their psychosocial development. Overall, this slide talks about the developmental needs, psychosocial developmental needs of the adolescent through all the stages to be able to become a functional and adjusted adult. Physical development in the adolescence focuses a lot on the reproductive tract, and we talked about 5 Tanner stages. It's important for a number of reasons to see that their endocrine, neuroendocrine, and reproductive systems are developing normally, which is a major physiological task of the adolescents. And also, in some particular pharmaceuticals, we want to know where they are in their Tanner staging in order to dose them appropriately. So it's important to document the development as both boys and girls go through the Tanner stages. This slide shows breast development. And then this slide shows the 5 stages of pubic hair distribution. And then external genital development in the female, of course. For males, we see the hair distribution occurring stages 1 through 5. And that mirrors the female hair development. And then the external genitalia. Of note is that scrotal development, testicular development precedes penis development. Because this is the age when people develop their secondary sex characteristics and their reproductive capacity, sexuality is a major issue in adolescence. It's important to normalize it for the patient, that the things they're experiencing, which are very new to them, are not unique to them, and that is generally reassuring. That exploration is a part of the learning process, and that there are boundaries to safe exploration to avoid STIs, to avoid unwanted pregnancies, and to avoid entering into relationships that are abusive. Moving on to the physical exam. In terms of history, we want to review their immunizations. We have a slide coming up about immunizations specific to the adolescent age group in a moment, but we want to make sure that they got their childhood immunizations, and if they didn't, we'll do catch-up. There are very good resources available at cdc.gov/vaccines to help you figure out how to do catch-up, which can become very complex. And I recommend that you do, as I do upon recommendations of others that trained me, always refer to a reference. Don't try to do that from memory. It's very complicated. We also want to focus on visual acuity because it is at this age that we may see the development for the first time of problems with acuity. Would include cardiac, respiratory, and musculoskeletal, abdominal and genital urinary, GI, the onset of menses, watching for amenorrhea, primary or secondary, and that things are coming together. You expect some irregularity initially, but within a short time of the first menses, the expectation is that adolescent females are having regular periods. Their skin, mental health and happiness, and a stable and supportive living situation, all would be in your history. On clinical exam, you're going to have vital signs. This could be the first point at which you would see two conditions emerging. One would be hypertension. We will talk about that more in depth in the full lecture. And also obesity. With the growth spurts that happen during adolescence, most kids, even if they were a little on the plump side, in younger years should start leaning out, and continued particularly abdominal obesity as they move into middle adolescence is a reason to start discussing diet, exercise, as well as looking for any physiological causes. It's important to note, though, that we're not going to be setting rigid calorie counts or putting undue attention to weight loss, because data shows that taking that approach to overweight and obesity in this age group can stimulate eating disorders. So it needs to be done with a gentle hand. AGENT and eye exam, as we noted, dental exam, the teeth have all converted by this point to their adult dentition, skin evaluation, the typical pulmonary, cardiac, and abdominal exam, Tanner staging for both men and women, and then a good musculoskeletal exam, looking in particular for scoliosis. Sometimes scoliosis, which has appeared earlier in life, resolves as they grow, or it can become worse. So even if it was absent in the past, you're going to look for it, and if it's been present at 5 degrees of scoliosis or less, we would be looking to see that reducing and not increasing. And if it did, that would be a reason for an orthopedic referral. This just runs down things you want to be sure to ask. It's a little redundant to an earlier slide on adolescent history, but some key things to talk about. Here's the slide on vaccinations. Tdap, they're going to need one between ages 11 and 12. Meningococcal, if they get the first dose between ages 11 to 12, it's a single dose. 16-year-olds will get one dose and a booster if the first dose is before age 11. So that's the MCV4 vaccine. MenB, which has two brands shown here, Bexsero or Trememba, is in addition to the Menectra and is given between the ages of 16 and 23 years, and you can see the dosing schedule there with both being Bexsero and Trememba being two-dose series. What's important to know about MenB vaccines is once started, you have to give the second dose of the same brand. So if they started with Bexsero and they come to you and you only have Trememba, you're going to need to make a determination with the patient and the parent if they want to start over with Trememba, meaning both doses, or find someone who can provide the second dose of Bexsero. Strongly urge people to, both the females and the males, to get the HPV vaccine. It is protective against not only cervical cancer, but pharyngeal cancers in boys and girls. And if it's given between 9 and 14, it's the two-dose series. And if it occurs after age 15, then it's a three-dose series. Influenza should be done annually. And again, a reference to the CDC site on vaccines schedules. So a lot of the physical exams that happen in the the adolescent and the older adolescent are done in to clear them for participation in a sport. So here is an outline of a typical physical exam for sports clearance. Typically, the patient will arrive with a form provided by the team that outlines what it is that they need to have done. I've bolded heart sounds here because looking for cardiomyopathy involves listening for murmurs in different positions. And you will go over this in detail as we go through cardiovascular in this course. But you're going to have them squat, stand, lie on their side, and listen for changes in their heart sounds, in particular the emergence of murmurs in certain positions. They need an abdominal exam. The GU exam only needs to be done in males really looking for a hernia. Skin, neurological, including reflexes and cranial nerves, and then a good musculoskeletal exam. And the outcome of that would be full clearance or restrictions on sports activity. So what are restrictions? Well, contraindications would be active myocarditis or pericarditis, enlargements of the liver or spleen, because in a contact sport, those organs could be damaged. Eating disorders, if the patient is not being compliant with a therapeutic plan. History of recent concussive or symptoms of post-concussion. Hypertrophic cardiomyopathy, which can lead to sudden cardiac death. Long QT syndrome, which you would only get on EKG. And that is not routinely recommended by the pediatric societies and the cardiology societies. But if you have an EKG for some reason, you would look for long QT syndrome. Or if they're on any particular medicines that could cause long QT syndrome, you would want the EKG for that. If they have seizures, you want to know how well it's controlled, because you wouldn't want them to be engaging in activity where they could be seriously injured in the event they should have a seizure. Hypertension, would be a reason until it's controlled that they should not be participating in sports and anything that would lead you to suspect coronary artery disease. Sickle cell disease is also a reason for not clearing them for high exertion, contact, or collision sports. The risks, when you're thinking about what are the health risks for the adolescents, fall into 4 areas: individual factors, societal factors, community factors, and relationship factors. There's some very good paper and pencil or electronic screening tools that you can use in your practice to screen these patients as they come through. And these are discussed at length in the longer lecture. But to be aware that it is appropriate to be screening using these tools in this age group. More about sexual behavior because it is a risk factor for this age group. This is data from a behavioral risk survey. It's a subset of the BRFSS, showing in high school students, about 40% had intercourse, about 3% had intercourse before age 13, about 30% were currently sexually active, almost 50% did not use a condom during their last sexual intercourse. That's a problem and something that's worthy of some discussion in private with the patient. About 14% did not use any method to prevent pregnancy during the last sexual intercourse. And then 80% did not use birth control pills, an IUD or implant, or a shot patch or birth control ring to prevent pregnancy. So what does that mean? Well, what that means is, why would 14% say we didn't use any method to prevent pregnancy, and yet 70% report not using what we would think of generally as any method to prevent pregnancy? The difference is that the 13 didn't even use coitus interruptus. Or probably a condom. So what we see in the yellow bar, 70%, pills, IUD, implant, shot, patch, birth control ring, those are reliable. Those have an efficacy above 90%, all of them, and most of them up around 98% to prevent unwanted pregnancy. Condoms can achieve that if they're actually used, and coitus interruptus has a very low efficacy rate. And so that is something to talk about with both boys and girls, that plan as a way to avoid pregnancy is not effective, and they need to choose something that is effective, and you can help them figure out what would work for them. And then 18% drank or used alcohol in relation to their sexual activity. That's important because the disinhibition of alcohol means that they may not take reasonable precautions to avoid transmission of STIs in pregnancy if they're under the influence of drugs and alcohol. A little bit about adolescent pregnancy. Excuse me. The pre-participation physicals that we talked about earlier have these purposes, and that is really safety, to maintain safety, to rehabilitate old musculoskeletal injuries, to identify and treat conditions that interfere with performance, and to remove unnecessary restrictions on participation. The practice recommendations are to cover 12 components for the pre-physical exam, or the PPE, recommended by American Heart to screen young athletes for potential life-threatening cardiovascular disease. Perform a general urinary exam, as part of the PPE for young men, assess young women for the criteria associated with a female athlete triad, and that's C-level evidence, and to perform auscultation while the patient is squatting and while doing the Valsalva maneuver to determine any murmurs you detect on examination associated with hypertrophic cardiomyopathy, and you will have an opportunity to practice that while we're in the lab. So what about ECG testing? I mentioned this. It's really not recommended by the AHA guidelines. It is recommended by the European Society of Cardiology, and it's a law in Italy. So when should EKG testing be done? It should be done if you have a reason to believe that there's a problem. Or as I said, if they're on medicines that could cause prolongation of the QT interval, then you should get an EKG. Other than that, you do not need to routinely screen ECG as a way to find arrhythmias or cardiomyopathy. You can find that with your physical exam and the positioning that you will go through as you auscultate their heart sounds and the distortion of their point of maximum intensity. So there's physical findings that you can use to feel confident that you're not dealing with cardiomyopathy, and you don't need to get an ECG on every one of them. You'll also detect arrhythmias if you're doing your auscultation of the heart for a long enough period, which should be at a minimum 1 full minute. So then we're also concerned about this triad of athletic problems in young women. And one of them is menstrual dysfunction athletic amenorrhea. It's a diagnosis of exclusion. Remember to rule out pregnancy. Check on nutrition. And then you may want to do some hormonal testing to see, one, do these women have at least biochemical markers of PCOS, and should you get an ultrasound? And also, do we have them exercising to the point that they have distorted their hormonal balance? I'm sorry, I think we've already seen this. Just a little more detail about suspected coronary artery disease, impairment of patients with left ventricular systolic dysfunction less than 50%. These would all be things that you would get on history and then would send them on for echo, stress testing, and so forth. Really a repeat of the prior slide, but always a good review. Some final thoughts. Engage the patient in his or her care and in decision making. Don't preach. Provide information in living room language that they can understand. In adolescence, you're developing a relationship with your patient more than with a parent as they approach the ages they're going to be in participation in sports, but in middle to older adolescents, you need to develop the patient relationship. Health promotion and primary disease prevention is the keystone of caring for adolescents. Praise them for good decisions, and above all, be supportive, non-judgmental, and listen.